Hey everybody, good morning. I have a couple of you in here so far. Let me know if you can hear me. I'll assume you guys can hear me until proven otherwise. I'm gonna start here in just a few minutes. Yeah, that's okay. I'll wait a minute or two. They can catch up if need be. Not too many people had technical issues, but all right. See how many people. About 8. Not too bad. Hopefully the test wasn't too terrible. I said I didn't receive any questions beforehand, so I'm assuming either I did a bang up job teaching you guys or something else was going on, but hopefully everyone did well. I'll check out the stats after the fact and then, see if there's any high misses or any kind of. Let's see. Maybe just like 2 or 3 more minutes just to see if anyone else wants to pop in. Julia. Get a few more people in, so that's good. On 9:05, that'll work. Was there any of you guys watching like in a big room together by any chance? I think so, Dallas. I'm having a pretty good morning. Better so than my 3-year-old's having. She had a bad night's sleep last night. Sorry if some of you guys are stuck at home. It's fortunate. Hope everyone's well though. Hope everyone's healthy. About 19, 18 people in, so I'm gonna go ahead and get started actually. I apologize about screaming child in the background if you hear anything, but this is what it is in the morning sometimes. You got kids. Someone did have a question. They were asking about risk for things like Ray's syndrome when you have patients, especially younger patients, taking things like mesalamine for like Crohn's disease and RA and stuff. That can happen. That's a risk, certainly. So I would be concerned about that if I had a kid less than 16 who needed to get that. It can happen, you know, especially with kids with, you know, kind of a host of rheumatologic issues. You know, so they have like type 1 diabetes and Crohn's and, you know, other stuff too. They can all kind of culminate together, or they tend to come in packs together in some cases. So that's a risk, but I wouldn't be too concerned about it. Oh, excuse me, I thought my door was locked. 1 second. Sorry about that. Nothing like a little bit of morning chaos. Anyway, kids are great. I love them. Fantastic. All right. So let's see. So in regards to the test, I'll go ahead and take a look at it. Look at the stats, see if there's any issues from like, you know, either miss key or high miss questions, and I'll let you guys know if there's any givebacks or anything. I apologize. I'm a little delayed in getting your prescription assignments graded. Planning on getting those done today, and I'm gonna give you an extension on the second prescription assignment, so don't worry about that. You'll have your feedbacks, that way you can have some info kind of going forward with that. Anyway, so let us continue on talking about neurology. Let's see here. So basically we're gonna start off by talking about epilepsy. This is kind of a big section. Hopefully you guys can all see the PowerPoint there. Okay, that's okay. As long as I got to take the exam at some point, Kelly, that's fine. They can come back and watch the video later. So, anyway, so looking at epilepsy, basically, you know, seizures are kind of this abnormal discharge of these cortical neurons, right? And so what we're mainly going to be seeing is that because you're having sort of this unorganized, sort of hyperexcitable set of neurons firing action potentials, we're going to try to stop that by trying to hyperpolarize those neurons and prevent them from being so excitable. And so we'll see there's kind of a host of like side effects that are pretty commonly seen with meds that are used to treat seizures, because they'll have basically the ability to try to hyperpolarize those neurons and really kind of slow them down, so to speak. And so we know what kind of typical tonic-clonic seizures sort of look like, and there's also something called status epilepticus, which is sort of that continued seizure activity where patients either are continuously seizing despite treatment, or they are unable to return back to their baseline mental status in between seizures. That can happen, patients, when they have a seizure and they've recovered, they'll go into what they call post-ictal state, where they're not really at their baseline mental status. They'll usually be pretty sedate looking, maybe not answering questions appropriately, but then they'll get back to baseline. That may not happen in someone who's like in true status epilepticus potentially. Of course, there's lots of things that can cause. I'm gonna give you guys an extension, so I'll make it due next week. So I'm gonna go change that due date, so don't worry about that, Erica. So when trying to determine if a patient's like why they're having a seizure or something that can disrupt neuronal stability, a lot of things can do this. So certainly I'm sure most of you are experiencing some of these, like sleep deprivation and emotional stress, but a lot of other things too, like medications can do this. So certain antidepressants, and interestingly enough, having too high levels of anti-epileptic drugs can do this. Or if you're not compliant with your anti-epileptic drugs, if the AED, that's what that's referring to, is anti-epileptic drugs. So we'll have patients, who may come into the ER for seizures potentially, and we'll check a level, and it could either be too low because they're not taking it for whatever reason, or it could be way too high because maybe there's some drug interaction or something happening there. So it can kind of go either way. Just like we saw with antiarrhythmics, they can cause arrhythmias. These can cause seizures too in some cases. But basically what we're seeing here is that, as I mentioned, the neurons are hyperexcitable. Two primary things that are going to be affecting this, or two primary neurotransmitters, is going to be GABA and then glutamate. GABA is going to be sort of that major inhibitory neurotransmitter. I think about GABA as sort of being like the brakes on the car, so to speak. And then glutamate's the main excitatory neurotransmitter that causes the neurons to be more likely to fire. And so that's kind of like the gas pedal. And so you can see a disbalance there. If you have too little GABA or too much glutamate, that can end up leading to seizure activity. And so when looking at the excitability of these neurons as well, some of these things that can affect this include the resting membrane potential for a neuron. So if you were to look at the electric potential of a neuron during an action potential, you would see that it has sort of a resting membrane potential, and the higher or lower that is set may make the cell more likely to fire off or less likely. So the more positive it is, the closer it is to that threshold to have an action potential occur, which may lead to a disorganized firing and lead to a seizure. If it's lower, and you're going to see it's more hyperpolarized, it's less likely to have that action potential fire off, and then maybe less likely to have a seizure. So, and that also can affect things like your refractory period in between action potential. So if you have a reduced refractory period, that can lead to sort of inappropriate, too early firing, and again, that can lead to that seizure happening. Obviously, when trying to diagnose patients for new onset seizures, it can be pretty complicated if there's not like a big smoking gun like meningitis or something like that. But a lot of things you can do, including like MRIs and EEGs, tox screens, things like that, can be useful here in determining why they might be having an actual seizure. And again, depending on the cause for it, the treatment may be very different. So for instance, if an infant's coming in with a fever and they're having a seizure, a febrile seizure, that is treated by giving them antipyretics versus giving them an anti-epileptic drug, right? Our goals for these patients, obviously we'd like to get down to no seizures, but that may not always be possible depending on how severe their case is. Even sometimes getting them down to just a few seizures a day may be really beneficial compared to what they're normally sitting at. We'd like to have no side effects, but we're going to find that's not going to be possible with a lot of the medications we have here. And overall try to improve quality of life and help to address any other like comorbidities and things like that. So, and sometimes you'll find you can actually have double duty being played by some of these medications, especially if they have like, behavioral health issues like, bipolar disorder. You can find some crossover here between some of these classes of meds, which we'll get into in the behavioral section coming up next as well. But things you want to consider, including patient age, because this can affect the pharmacokinetics of the drugs pretty significantly. Just to give you an example, something like phenytoin, you can see how the daily dosing changes pretty greatly based on their ability to metabolize it. So little ones, 6 months to 3 years, can metabolize it much faster than, say, someone who's 10 to 16 years of age. And so that's important because you have to go back through when you're readdressing these patients to make sure to adjust their dose to keep their levels consistent. Otherwise, you may find you're giving them too much, too little, and that can lead to either side effects or more seizures happening. And again, what's their ability to even comply with the medical regimen? If they're taking 2 or 3 different medications at different times a day, that can lead to non-compliance. If they're traveling, for instance, and they forget their meds, that can be a big precipitant for having seizures occur, especially here in Florida, since back in the pre-COVID times, we'd have a lot of travel and people coming into the state. They forget their meds at home and then present to the ER for seizures. And things like insurance coverage can be important as well. Make sure, because they can't afford the medication, they're obviously not going to be compliant with it. Now, what you're going to find with these drugs here is that none of these are disease modifying. So none of them cure the seizure. None of them are really going to do anything if they're not present. So if patients need to be on them, they're likely going to be on them for quite a long time, if not forever. You'll find about 2/3 of patients are going to be well controlled on just monotherapy, so just one drug, but there will be a subset of people who do require more than that. So maybe 2 drugs, 3 drugs. And then when it gets a little bit more unmanageable, when medical therapy itself is not good, then that's when you can get into some other cases or other modalities, things like surgery. There's been cases where people will have sections of the brain removed because it happens to be just a particularly sensitive area that causes a lot of seizures, if you can identify one area that does that. Or we may even put patients on a ketogenic diet. Most people are familiar with keto diets nowadays, I think, but again, this is a diet that is going to be very low in carbohydrates, almost none, in order to put the patient in a state of ketosis, which does make them more acidic, makes their pH drop to a small degree, and that actually can lead to it having your cells being more hyperpolarized. It actually makes it more difficult to have a seizure if you're more slightly acidic. And so that's one thing we might do for more refractory patients. So looking at how we're designing our optimal regimen here, frequently you'll find that the drugs can be pretty effective. They're good at preventing seizures from happening here. But it could be issues of things like drug interactions or adverse effects that make it really untenable for the patient to continue on that therapy. And so that can be a big issue to where the drug may be working very well, but if they're having such bad side effects, they're not going to take it. That's obviously not going to be great. And so you want to look at that. You want to look at things like the mechanisms of the drug. So that way, if you need more than one, you can try to use complementary mechanisms, so ones that work well together, instead of using 2 of the same mechanism, for instance, and looking at things like compliance and cost and whatnot. So monotherapy should be used first for these patients here, and then we'll add on additional drugs if we don't have good seizure control. So this is important for patients to make sure they're keeping like a diary, or their family members are keeping a diary for them, to make sure that we can track to see if there are any like particular precipitants. Is there certain times of day where these are occurring? These are little things that can kind of clue us into maybe how we can adjust our therapy to be a little bit more effective here. And then, as I mentioned, if you have kind of failed multiple attempts at drug therapy, that's where we get into the non-pharmacologic therapy. And again, I'm not going to talk too much about that, mainly because it's not really in my purview. But certainly, we have to deal a lot with, not a lot, but sometimes you'll have these kids that come in on ketogenic diets. And from a pharmacy perspective, that's actually really important to know, because especially with kids, a lot of times if you're giving them medications, we have to give them as liquids. And so what do they put in these liquid medications to make them more palatable by the patient? Well, they put sugar in it, and it makes them nice and sweet, right? So just like Mary Poppins says, spoonful of sugar helps the medicine go down, but that's going to also throw your patient out of ketosis and may precipitate seizures. So if you ever, for instance, like have a patient who you see has a dextrose allergy, that seems pretty silly, because how could you be allergic to dextrose? You'd be probably dead. However, that's our signifier to say, hey, this patient's on a ketogenic diet. Make sure you're not going to give them any extra carbs that could affect their ability to stay in ketosis. So generally speaking, you titrate slow to see how the patient's going to respond to this, to find kind of the sweet spot in terms of efficacy. versus any kind of toxicities the patients may be developing here. And a lot of these do require therapeutic drug monitoring. So we'd have to go ahead and look at the levels of the drug in the patient's blood to see how well they're working. You can do this to monitor to see, if they're having excessive seizures and maybe the level's low, that can clue you in, or if the level is high, that may be why the patient's experiencing side effects. And so we can use levels to help us with that. And again, we may need to change therapies based off of either not controlling seizures very well or due to the adverse effects. If that occurs, then you can either try switching drugs. You can try switching to a different class. In some cases, if you're already on maximal doses, you may add something on. But again, consider looking at different mechanisms and see how we can try to use complementary therapy to get best control of this as we can. So here are the main targets we're going to be looking at for our anti-epileptic drugs here. We're going to see that these first 4 are going to be kind of our main mechanisms we're going to be focusing on. These last 3 are going to be sort of miscellaneous sort of drugs, which I won't talk about too much. But again, be able to recognize the mechanism that a drug class falls into, right? That way you can kind of determine, okay, which one of these would be complementary. If which ones of these are sodium channel blockers versus calcium channel blockers, and that can clue you into how they may work well together, or maybe not so much if they're doing the same thing, basically. But looking at sodium channel blockers here, this is basically, if you were to look at the diagram of the electric potential of a neuron during an action potential here, remember that normally the cell will be sitting at this resting membrane potential, and once a signal comes along, usually another action potential from another neuron, this causes sodium channels to open, which you can see right here, and that causes depolarization to occur. By helping to block these sodium channels, the speed of this that happens is going to be slowed down, and also the ultimate amplitude of the peak here is going to be reduced as well. And so that's going to help us to extend out our refractory period. It's going to make the cells less hyperexcitable. That's overall going to lead to less action potentials, which is what leads to its anti-epileptic activity, which is good, but it also can lead to some of the side effects, as we'll see there. And just like on the heart, the sodium channel will exist in these 3 states, where maybe in the resting, active, or the inactive state. Mainly our drugs are going to be focusing on the inactive forms. That way it's able to extend out and prevent these cells from sort of resetting themselves as quickly, and that helps out with that refractory period and extending that, which is good. So you can imagine here what this will look like, where you have the sodium channel that's open that allows sodium to flow into the cell, causing the increase in electric potential, versus here where they have the inactivated state. If we can have the drugs block this, and that helps to keep it inactive for longer. As I mentioned, it helps to reduce the overall number of action potentials occurring, and will extend out that refractory period. Here's some example drugs that we're going to get into in just a little bit, so you can refer back to this when trying to sort of suss out their mechanisms here when we talk about them in more detail. We also have calcium channels. Now, these are not the same calcium channels as what you would see with your traditional cardiovascular calcium channel blockers. Those were mainly going to be the L-type calcium channels. The ones we're going to focus on here are going to be the T-type calcium channels. So these are more predominant in the CNS. And so, for instance, drugs like ethosuximide work specifically for that. You're going to see a little bit different flavor in terms of how they're working. So, for instance, different seizure types may respond better to different types of therapy. One really good example of that would be absence seizures, which is very different than the typical like tonic-clonic seizure, where they basically have like staring spells. I oftentimes can induce this in a lot of my students. I just see them staring off blankly into the distance. That's usually as a result of my lectures. But regardless, by targeting certain channels, you may be able to get more efficacy out of utilizing certain drugs for that particular seizure type. So I'll mention that more specifically in a little bit. Here's what this will look like. So again, calcium flowing into the cell would increase the electric potential, causing them to be more hyperexcitable. Blocking calcium, again, helps to reduce that. So the overall amplitude of that potential is going to be reduced. Next we have GABA. So we're going to talk about GABA A primarily here. If you recall, we did talk about GABA B being more so used in regards to things like muscle relaxants. So things like cyclobenzaprine and whatnot were better at inhibiting or activating GABA B receptors. Here we're going to focus mainly on GABA A. And what this does is when it's activated, when it's open, as a result of interaction with GABA, it allows for chloride to flow into the cell, right? So as opposed to sodium flowing in, which makes the cell more positive, chloride flowing in makes it more negative, and that again hyperpolarizes it, makes it more difficult to have the action potential. And so again, we can try to do things to either enhance the GABA that we already have, or we can try to use drugs that open up the GABA A receptor itself, or the actual channel itself more directly, and that can all lead to hyperpolarization. As we mentioned, GABA B is more so seen with the skeletal muscle relaxants, which we already have covered. There's a couple of ways we can affect the system here. So for instance, one, we can try to modulate how much GABA we actually have available to us. So we can either do things like try to modulate the enzyme glutamic acid decarboxylase. This is actually an enzyme responsible for converting glutamate into GABA, so converting the excitatory neurotransmitter into the inhibitory one, which is kind of interesting. So that way we would have more GABA available to release into the synapse. We could do things like trying to block the reuptake of GABA so that once it's released into the synapse, it's not able to be sucked back up into the presynaptic neuron as easily. So you have just more of it around in the synapse to interact with postsynaptic receptors. One way you could do things. You could do things like trying to block the metabolism of GABA. So that way you just, again, have more of it available. You could either try to increase the production or decrease the metabolism, ultimately leading to higher GABA levels. So there's an enzyme called GABA transaminase. If you inhibit that, you'll have higher levels. And then what's done more commonly, and this is something that you'll see done predominantly, especially for like acute treatment of seizures, is going to be things that bind to different areas of the GABA A channel. They basically bind to a different site and allow for GABA to work more effectively. They sort of act as an enhancer of GABA to allow for the channel to open more quickly or more often. And again, that allows more chloride to flow through. This is where we're going to get into our barbiturates like phenobarbital and then benzodiazepines as well. Some of which we've kind of discussed a little bit already. And you can see here how some of these different mechanisms might work in sort of the life cycle of GABA, where you can have things like GABA transaminase being inhibited, so that way you have more of GABA around. You will find things that will cause the reuptake of GABA to be inhibited. So for instance, here tiagabine basically blocks that reuptake. And then, as I mentioned, things like benzodiazepines and barbiturates can bind to different sites on the channel that allow for GABA to work better at those GABA A receptors. So that'll be an important way to treat acute seizures, as we'll see here in just a little bit. So, and then again, as we mentioned, glutamate is a very excitatory and usually allows for things like sodium and calcium to flow into the cell. And so if we can inhibit that, that ultimately decreases the hyperexcitability of the neurons as well. This is a little bit of a newer mechanism for some drugs. You don't see as many drugs that do this, but there's certainly some that we'll talk about briefly as we get into them. Now, there's over like 20 of these that are available, and they can be quite different from one another. And so I won't cover every single one of them because some of them are still really new. You're probably not going to see used as often, and we don't have as much clinical experience with. However, I'm going to cover the ones that are like tried and true, bread and butter kind of anti-epileptic drugs you're going to run into pretty commonly. It's difficult to do a head-to-head trial between these agents here because, again, seizures themselves can be unpredictable in terms of severity, in terms of onset. So generally speaking, you're selecting it based off of individual patient response, seeing how the patient and what the comfort is with the provider using the drug, things like that. So I'll get into some of those details as we move forward. Phenytoin is the first drug we're going to be mentioning here. Phenytoin basically blocks sodium channels. This is the first of our sodium channel blocking drugs here. And is also pretty interesting from a kinetic standpoint. This one can be a little challenging to work with because one, it's highly protein bound, about 90%. If you recall, when talking about protein binding, only the free drug, the drug that's not bound to proteins, is able to be pharmacologically active. So we'll see there's a lot of drug interactions where it can affect how much of it's available to interact, and that can lead to either side effects or maybe less of the drug is effective, as we'll see in a little bit. And there's also a ton of kinetic issues. From a metabolism standpoint. So for instance, it's metabolized by CYP2C9, 2C19. However, interestingly, this drug can induce CYP3A and 2C enzymes. So if you had someone who's on, say, CYP3A4 in metabolizing drugs, this can induce that and cause levels of those drugs to lower because you have more enzyme available to metabolize it, for instance, right? So again, being aware of these drug interactions is really important, especially if you're initiating a new drug for these regimens, because it can get pretty complicated especially if they have comorbidities and other drugs that they're taking. And so these are generally, and most of the drugs we're going to talk about here are going to be generally broad spectrum, meaning they treat a variety of different types of seizures. So I'm not going to ask you on an exam specifically, does this one treat partial or generalized seizures? Unless it's an absent seizure, like they kind of work for all of them for the most part. You may find some work a little bit better than others, but for the most part, these are broad spectrum antiepileptic drugs. We'll talk about absent seizures specifically with one particular drug here in just a little bit. Generally speaking, with all these drugs here, you're going to find that lethargy, blurred vision, ataxia, fall risks are going to be seen with almost all these drugs. And that makes sense because you're inhibiting the neurons, preventing them from firing as often or as strongly. So it would make sense you'd have some mental slowing and some of the things that go along with that. Nystagmus can be another pretty common thing you'd see with patients with phenytoin on board. Some other things that are sort of more unique to phenytoin include things like hirsutism, which, again, if you're starting this on a young lady, might be kind of distressing to her from that standpoint. And good oral hygiene is really important for these patients as well because they can develop what they call gingival hyperplasia. So good teeth brushing regimens and things like that help to sort of keep the gum from getting too hyperplastic there. Other issues you can run into are some interactions with vitamin D, causing deficiencies, which may lead to osteomalacia in chronic cases there. And there are risks for things like rash and Stevens-Johnson's. If we haven't talked about that before, that Stevens-Johnson's is a very severe skin reaction you can find in some of these drugs here that is quite life-threatening if not caught early. So this would be a thing where you'd educate the patient, hey, any new rash, any new blistering, if you notice any ulcers in the oral mucosa, anything like that, it could be indicative of Stevens-Johnson's. You want them to stop taking the drug and coming to get evaluated, probably at an ER, like immediately. So there's several drugs that can do this. I'll sort of highlight those as we get into the specific adverse effects a little bit later on. But phenytoin itself, a very good broad spectrum drug. You can use it for all types of seizures. I've seen it used for a long time as a first line agent in a lot of cases. That's starting to change a little bit nowadays, but it's still a very good drug. You can still use it pretty easily. You'll see a lot of patients who are using this, I'll say. As I mentioned, the protein binding can be an issue here. So if you have a patient who, for instance, has low levels of albumin, that would lead this protein binding level to change. It would actually have a higher free fraction. So instead of saying going from 90% protein bound, it may drop down to like 85%. Now, it may not sound like a big change there, but you're now going from 10% free to 15% free, and that's a 50% increase in the free fraction of drug. That can be a big reason why you'd have patients experiencing more side effects from the drug because more of it's available to interact with those sodium channels. So you can see this more often in patients who may have like chronic malnutrition, who have low levels of albumin, renal failure, multiple drugs maybe that are competing for the same binding sites. So that is certainly something you want to look for. And that's why you can check levels for the drug. You can look for either a total level or you can look for a free level. And the free level will actually tell you what amount of it's actually physiologically active. Now, phenytoin itself, if you think about someone who's having a seizure, you will see that oftentimes they're not able to take anything orally because they're not really protecting their airway very well. They could aspirate drug. So you have to think about how you're giving the drug itself if someone's having an acute seizure. You could do IV if you can get one started, right? Maybe difficult if they're having tonic-clonic seizures and they're moving around a lot, but that's one way to do it. You could do intramuscular, and then rectally administered drugs too has kind of been used on the outpatient basis for a really long time. I'll talk about some options for that in a little bit. Nowadays, we're starting to use more intranasally administered drugs as well as sort of a newer development. Now, IV phenytoin itself is a pretty nasty drug. It's hard to get into solution, so you have to make it like at a really high pH of like 10 to 11. There's all kinds of other stuff in there to make it go into solution. It's really tough on the veins. You can cause things like phlebitis. And here's a picture of someone who had phenytoin extravasate from probably a vein in the hand that was being used, the blue, and that can lead to a lot of tissue necrosis. And that's probably a one way ticket to a lawsuit if I had to imagine from a picture like that. So in order to prevent that, we either want to make sure that we're using like a really deep vein if possible, if not central administration, or we also have a variety of the drug called phosphonitoin, which is a more water-soluble form. Basically, they just pop the phosphate group onto phenytoin, and you got phosphonitoin now. And so that's good because you can give it intramuscularly, you can give it IV, and it doesn't cause as much irritation to the veins. And then once it gets metabolized and that phosphate popped off, then now you have phenytoin again. it can have its anti-seizure activity. So pretty cool from that standpoint. Some people may ask, why would you ever use regular phenytoin IV ever? Sometimes there's shortages, sometimes there's issues, and we had one case where phosphonitoid went on recall, not because the drug was bad or anything. It was because there's actually glass particulate from the vials that they were using that were causing issues for patients. And so sometimes it's more of a production issue than it is a drug efficacy issue. So continuing along with our sodium channel blockers, we have carbamazepine or Tegretol. This one also has a host of pharmacokinetic issues, mainly from the fact that it can induce a lot of CYP enzymes, just like we saw with phenytoin, so things like 3A4, 2C9, etc. We're also going to find here that it actually induces its own metabolism, and so you actually have to have sort of a built-in titration where you kind of gradually increase the dose to account for the fact that its own metabolism is speeding up. So you'll find that in some cases you'll see that, okay, in week 1 you're dosing like this, and then week 2 you increase it, week 3 all the way up to week 4, where normally you'll have sort of a balance and equilibrium that's achieved there. Notice here is pretty similar side effect profile in terms of like diplopia, dizziness, things like that. And here you would want it to monitor renal, liver functions because you can see increase in LFTs. LFTs are probably going to be monitored for most of these patients here, just because of the fact that a lot of these drugs can cause some issues with that. Interestingly as well, sort of a unique side effect to carbamazepine and its cousin oxcarbazepine is they can both cause hyponatremia. The reason for that is they can cause something called SIADH, or the syndrome of inappropriate antidiuretic hormone. Normally, antidiuretic hormone causes your kidneys to hold on to water, and that dilutes out the salt in your blood because your blood volume is going up, but the salt's not, still being able to be urinated out normally. So in those cases there, you can find hyponatremia. So sodium you have to monitor for this one, and oxcarbazepine, even though this one's a little bit less. You also want to look at the CBC for this drug because you can find some bone marrow suppression. So things like thrombocytopenia, leukopenia would be something you want to monitor for as well. As you can tell, these drugs, even though they may be really effective for preventing seizures, you're going to find a lot of monitoring that goes along with these drugs here. Next, we have oxcarbazepine or trileptal. This one is, again, a cousin to carbamazepine. It's nice because it has fewer drug interactions. For the most part, you don't find any enzyme induction, which is good, and it's kind of similarly effective, but the sodium issue is going to be bigger for this one. So you do want to monitor the sodium pretty cautiously with this one. Make sure that's not going to be getting too hyponatremic, because guess what can happen with patients who are hyponatremic? They seize. So it's hard sometimes to tell, okay, patient's seizing is because the drug's not doing its job, or is because maybe the sodium's too low. That's something you could investigate with a basic metabolic panel. Next, we have valproic acid or Depakote. You'll see Depakine, Depakon. If it starts with a Depa something, it's usually related to valproic acid. And so this one has a little bit of a mixed set of mechanisms here, where it's able to inhibit both sodium channels, also helps to block some calcium channels, and then helps enhance GABA activity. So good from that standpoint. A lot of patients do very well on valproic acid because you find that for the most part, like GI disturbances are like the biggest issue. You have some mental slowing and things like that, but it depends on the dose the patient's getting there. Of note, though, some things you want to monitor for include hepatotoxicity. You're monitoring LFTs. You're looking at the CBC for things like thrombocytopenia. And also, if you have a patient who's coming in complaining of belly pain who's on valproic acid, it could be pancreatitis. So you can look at things like lipase and things like that to see if something is going on from that standpoint. It's kind of a unique thing that valproic acid is able to do compared to a lot of other antiepileptic drugs. It's not a common thing that a drug will cause pancreatitis, but this is one of those instances there. This one can inhibit CYP2C9 and another enzyme system called UGT. It's a glucuronidtransferase. This can affect other drugs like lamotrigine and lorazepam. It's more of a case-by-case basis for that one than like 2C9, which is a little bit more broadly acting. And again, this is something that we would do therapeutic monitoring for to make sure that we're keeping it within the range there. For testing purposes, I'm not going to ask you specific numbers to memorize. I may give you a question where I have you do like a clinical interpretation of a level. So I'll say, hey, a patient comes back at a level of 25, and here's the reference range, and they're experiencing these side effects, or maybe they're having this many seizures. What do you want to do about the drug, right? There are cases like that where I may have you do like an interpretation. I can give you some more examples of that later once we kind of cover all this stuff. Of really important note too, this is teratogenic, meaning it can cause birth defects, and specifically this can cause neural tube defects, meaning you have things like anencephaly or microcephaly that can occur here. So very, detrimental to the developing fetus. And again, this frequently happens at the state of organogenesis, which is during that first trimester. So the challenge you run into is, and again, patients may be getting this for other things than just seizures, and maybe for things like, bipolar disorder and stuff we'll talk about in the behavioral section later on. But one of the big challenges you run into is that these patients, especially if they're of childbearing potential, if they get pregnant, obviously you'd want them to stop taking the drug immediately. But being pregnant is not something that is readily knowable, right? It's not like you have some big light bulb that goes off that says, hey, you're pregnant. So the challenge is if someone is, for instance, taking valproic acid, is able to become pregnant, they may be exposing the fetus to this drug for a period of time before they even know that they're pregnant, which obviously is not great for the fetus. So this is why things like recommending birth control or other types of contraceptions is really important, especially when you're looking at drug interactions. Things like estrogen-based hormones can be affected by some of these drugs here, so it's really, really important to make sure that patients have their options explained to them, making sure if they are sexually active to be aware of using good contraception and things like that, because obviously you do not want this to happen to a developing fetus, right? Anyway, so moving on, next we have our benzodiazepines. These are going to be really good for like acute treatment of seizure. So if someone's having an active seizure right now, these are like your go-to bread butter sort of drugs here. You'll find that these are very sedating because they do work to help enhance that GABA-A activity pretty significantly. So these may not be as good for like around the clock sort of usage because they can be sedating enough to where patients aren't able to really like pay attention. They may not be able to work very effectively or go to school or things like that. Certainly you'll see some tolerance to that sedating effect with all of these drugs, but especially initially on, you may find benzos are not going to be the best option for like kind of around the clock prevention of seizures. Like phenytoin, valproic acid are better for that. But if they're having a seizure right this second, this is a really good set of drugs, and this is the first thing they're going to receive. So we'll talk about more of these. We talk about anxiety in the behavioral section, but we have things like diazepam, lorazepam, midazolam, clonazepam, and clobazam. These are sort of the most common ones you're going to find being used for seizures specifically. This is also notable because these are the first ones that are going to be C4s, meaning they're controlled substances. And we'll find a few other examples of that moving forward. But note that you would have restrictions on how you're prescribing these. Whereas with something like valproic acid, I could write for a year's worth, no problem. Not me, but you guys will be able to. With this one, you can only do, say, for instance, 6 months worth because of the fact that it is a controlled substance that has those restrictions placed on it. Okay. Anyway, so especially for acute outpatient management of seizures, diazepam rectal gel has been used for a really long time. Obviously, that is a challenge because if someone's having a seizure, they can't give the drugs themselves, so someone else has to do it, right? So giving a rectal gel can be a little bit logistically challenging because the patient's writhing on the floor, for instance. You have to get their pants off. You have to be able to get the drug, make sure that the tip is lubricated, be able to insert it rectally so it don't cause any rectal trauma, and administer it. It's probably not the most graceful moment of that patient's life. So kind of was like the best thing we had for a really long time, but it wasn't like a really, kind of a dignified option, I think, in a lot of patients' minds. Nowadays, what we're moving more to is utilizing things like intranasally administered drugs. And so you'll find the nasal mucosa very good at absorbing drugs. And so we can use things like midazolam. And this is what I'm seeing a lot of our neurologists now recommending for patients, is that way they can carry this around with them. They have a seizure. Basically, you use the IV form of the drug. The patient's caregiver, whoever, would drop the drug into a syringe. They have a little device called an atomizer on it. Basically, when you spray the drug through it, it causes a very fine mist to occur, and that can just give it intranasally. And so if you think logistically, that's a lot simpler to stick something up someone's nose as opposed to sticking it in their rectum. So I think from a patient compliance standpoint, or not compliance necessarily, but a patient satisfaction, this is probably a lot better, especially if it, has a seizure out in public or something like that, right? Other ones you'll see used pretty commonly include lorazepam. I see this one, we use this all the time in the hospital for like acute seizure management. So if you come into the ER with a seizure, you're probably going to get Ativan for that. So that's pretty commonly used there for acute seizures. And then some of them that you'll see used sort of around the clock for more prevention of seizures would be things like clonazepam and clobazam. This is more so done like in pediatric patients who maybe have enough sort of other issues in terms of like mental disability to where maybe they don't have to worry about going to school or something like that. And so if that's not really a big issue, if you're able to deal with that sort of depressed mental status associated with these, and it's also treating that seizure, that may be a good sort of balance there. So it really depends on the patient to see what they really tolerate best in terms of both seizures and the side effects from the drugs. So you'll find that there's a lot of variability here with the benzos. Some of them are more water versus fat soluble. I'm going to talk about more of the differences there in the behavioral section, so just wait on that one for now. But as I mentioned, these are the go-to drugs for acute seizures. So you can get an IV, that's great, but if not, you got to think about your options. So either IM, intranasal, per rectum, whatever the case may be. And then the oral agents are going to be better for prevention of seizures as opposed to acute treatment of the seizures there. You'll see that the adverse effects, sedation is the biggest one you're going to see here. So everything along with that, including ataxia, impaired concentration, things like that are going to be seen pretty commonly here. And just note that with benzos, you want to be really careful if they're taking it around the clock, not to withdraw the drug sort of cold turkey. You have to make sure you titrate down off of them because you can see withdrawal seizures occur there, right? That's always a big question for patients coming in with a seizure. Is it because of the fact that they're having an actual seizure they would have had anyway, or is it because they're coming off of one of their medications? And this is a really common reason for that, is to have withdrawal seizures due to coming off of the benzos too quickly. Kind of leading from the benzos into the barbiturates here, we have phenobarbital, which is a pretty common one here. And again, all of these are working to help enhance the activity of GABA. So the GABA A channels are going to be working more effectively. They're going to be opening up more often to allow more chloride in to hyperpolarize those neurons. Phenobarb is probably going to be even more sedating than most of the benzos. And so because of that, we use it a lot of times for neonatal seizures. And again, a neonate, I don't really care what their mental status is so much because they don't really need to have, you can't really concentrate much anyway. So this is like a really good set of drug to use for that particular patient population. You may see it used in some other more difficult to treat seizure cases, but again, it's so sedating that we try to avoid using it if possible due to those adverse effects. And this is another one that will be a C4 as well, so another controlled substance there. So, as I mentioned, sedation, CNS depression, most common adverse reactions. Interestingly enough, for some kids, they may have what they call a paradoxical reaction when they actually get really hyperexcitable. So that's going to be more on a case-by-case basis, but you may see that occasionally. Note here, it also induces CYP2C9 and 3A4. So imagine if you had this plus something like phenytoin on a patient's profile. Anything that gets metabolized by CYP2C9 or 3A4, you're going to have to give really big doses to overcome that induction. So those would be things you want to be looking out for. And again, anytime you're adding a new medication to someone's regimen, just do an interaction checker. Most places you work will have availability of that, either through Lexicomp or whatever drug reference you use, but just run a quick interaction checker to see if you're going to run into any problems there, right? And so, as I mentioned, we'll use this most of the time like in neonates or for patients who are really refractory to everything else, mainly due to that kind of worsened side effect profile there. Some cases we'll also use it for things like refractory status epilepticus. So if like really nothing's working for the patient, they're still seizing, we may use our barbiturates from time to time there. And again, here's the therapeutic range. Don't memorize that number necessarily, but just know that this can vary greatly, right? Just because someone's level is a little high doesn't mean that that's a bad level for them. So for instance, if you had a patient who came in, really couldn't get their seizures under control, but they finally got put on phenobarb, and it seems to be working. They're not really having as many seizures as they were before, not really having any side effects, but you go ahead and draw a level to see where it's at, and it comes back at 45. You say, oh, the level's too high, you got to change the dose of the drug. Well, not necessarily, right? If the patient's having good effects from the drug, they're not having any adverse reactions, and the level's high, that may be just the right level for them. So, again, it always goes to the old adage, treat the patient, not the number. Sometimes the best thing to do is to do nothing, right? A couple other random drugs we have here include things like ethosuximide. This one is notable because it's a pure calcium channel blocker, and this is really the drug of choice for absent seizures. So this is the specific thing you're going to see this being used for. It's not really effective for many other seizure types. Everything else we've looked at so far has been pretty broad spectrum, can treat many types of seizures. This one is very specific, just for absence. Again, that's why we don't use it for a lot of other people, even though it has a pretty good favorable adverse reaction profile. Up next with gabapentin and pregabalin. We've seen this before when talking about neuropathic pain. These, even though they're structurally related to GABA, they don't really have the same effect as something like the benzo might, but it's thought that they can maybe enhance, calcium or block calcium channels, maybe enhance GABA synthesis. Not really sure how it works fully. We just know that it does have some anti-seizure activity there. However, I don't see it used too frequently for as an actual antiepileptic anymore. More often than not, I see it used for neuropathic pain, like probably 10 times out of 10 nowadays. But good to at least note here because it, this is what it was originally used for there. Okay, the biggest side effect is going to be CNS depression. And again, when you're looking at all these drugs here, it's not going to be useful to you to remember every single drug that causes CNS depression because almost every single one of them is going to cause that, right? Just know that in general, antiepileptics cause CNS depression. That's an easier way to sort of organize some of these facts in your mind. And just note the exceptions. If I say something is less likely to cause sedation, then you can make a note of that. Savannah's asking, this is a dumb question, I doubt that, but are you giving phenobarbital continually to patients in status epilepticus, or is it more of a one-time push thing like an adenosine for seizures? A lot of these are going to be used as like an intermittent sort of dose. So for instance, if I had someone with like status that came in, you'd probably give like 2 or 3 doses of a benzo to see if that breaks it. If that doesn't, then you start to kind of go down your line of different drugs, but you would, you had some like phenobarb, you'd give like a single dose and see if that breaks it. In some cases, you'll use continuous infusions of drugs if you're trying to induce like like a chemically induced coma. So for like really severe cases, there's another barbiturate, which I'm not talking about here today. It's called Pentobarb. And sometimes if a patient is really refractory to everything, nothing's working, they're still seizing, we can sometimes put them in what we call a Pentobarb coma. And that's essentially basically we're going to have to intubate the patient to breathe for them because we know their respiratory drive is going to take a hit, and we'll give them a continuous infusion of pentobarbital in order to keep them from seizing. So that is done rarely, but you may see that done occasionally. Yep, yeah, it just depends on the type of drug we're using there. Interestingly to note, pregabalin itself is a C5, but gabapentin isn't. So, it's a lot easier to get a hold of gabapentin. You'll see patients on just huge doses of gabapentin, but pregabalin, being a little bit more restricted, you may see a little bit less of that. Next we have lamotrigine or Lamictal. This one is really handy because I think I see this used more so like in adult patients because it is less sedating than you're going to see with a lot of the other drugs. So if you have to like go to work or something, this may be beneficial for those patients because it's going to cause less of a disruption for them. Although there are some interactions here to note. So you can see, for instance, that its metabolism can be inhibited by valproic acid or VPA, although it can be induced by carbamazepine and phenytoin, right? So looking at which drugs a patient's already on, if you were to add on lamotrigine, you'd have to take that into account. So for instance, if someone's on valproic acid, I'm starting a Lamictal, I'd actually have to drop my dose of the Lamictal in order to make sure that I count for that drug interaction. Or if they're taking carbamazepine originally and I'm adding on lamotrigine, I'd have to increase the dose, right? So again, these are things you want to look up to make sure you're using the right starting dose, make sure you're not giving too little or too much as the case may be. The biggest thing to worry about here is going to be the rash and skin reactions you can run into. This one's like really notable for causing Stevens-Johnson. Certainly carbamazepine is a risk, phenytoin's a risk here, but this is like really the big one you want to think about. If they have any kind of rash that gets starting here, have them stop taking the drug and going to get evaluated because if you don't catch Stevens-Johnson's early, it can be quite fatal, so you don't want that to occur. Excuse me, a little stuffy today. Next we have levetiracetam or Keppra. This one we are seeing a ton of use in kids, and again I see more pediatric seizure cases than I do adults nowadays. But Keppra is kind of our go-to preventative drug for a lot of kids nowadays. Most of our neurologists really like this. It has kind of a novel mechanism. It binds to the synaptic vesicle protein, or this SV2A protein, and actually prevents neurotransmitters from being released. Right, so actually prevents some of the more excitatory neurotransmitters like glutamate from getting out and causing hyperexcitability. And so I'm seeing this used either as like an add-on drug or just first-line therapy for a lot of kids nowadays, because it doesn't cause a lot of drug interactions. It doesn't really cause a ton of sedation. So from a just a disruption to their normal life standpoint, this is very minimal, and so that's why a lot of people do like it. If you do run into issues, it's usually going to be like in kids running into issues of like increased aggression. So that was one thing noted in the clinical trials, but if they certainly had any issues of like aggression, depression, things like that, I would be noting that. Make sure they're monitoring for any changes in terms of their mood and behavior, because this drug could affect that. So it's kind of a unique issue to Keppra. Then we have Topiramate or Topamax. This one is going to be used more frequently for migraine prevention, which we'll talk about later on in this section here. But this one has a host of different activities. It's able to block sodium channels, enhances GABA activity, and can antagonize certain glutamate receptors like AMPA and kainate receptors. Those are glutamate receptors there. I don't see it used as often for seizures. I don't know that it's quite as effective as other things like valproic acid or lamictal. However, note they do have renal dysfunction. You would want to monitor the dose for that. Make sure you can adjust it as necessary. And interestingly enough, it also inhibits the enzyme carbonic anhydrase, which we talked about briefly in the diuretics before, if you recall, acetazolamide back in the hypertension lectures. But this can cause things like renal calculi to form. So if they had a history of like kidney stones, this could affect that. Can actually cause a metabolic acidosis in some cases there. So you'd want to monitor for that. Yes, thank you for letting me know. I guess I can go ahead and yeah, this is probably a good stopping point because that's all the anti-seizure drugs. So anyway, so I'll go ahead and cut it off there. I don't see any questions. But yeah, so we'll work on finishing up at the next thing. We'll catch back up the next couple weeks here, so no worries about that. And I'll take a look at the test. But if you guys have any other questions, I'll stay on for a minute or two. Otherwise, you guys are free to go and get on to your next class. I'll check out the exam, make sure everything looked good there. I'm sure you guys all did well. I'm hoping. Yeah, no problem. Thank you for joining me. I appreciate it. Anything, so I'll go ahead and end the stream, and I will talk to you guys next time. See you later.